Welcome once again into the Radiopedia reading room, and welcome to 2024, the radiological year of the goat. My name is Andrew Dixon, and joining me, excited to share his New Year spatial resolutions with us all, it's my co-host, Frank Gaylor.
I don't do New Year's resolutions, Dixon. A whole year is way too long, and I'm easily distracted. I focus on much shorter time period. Like for today, my daily resolution is don't have a black Manhattan before 6 p.m. And it's not looking great.
Oh, gosh.
Do you have any resolutions this year?
More wishes than resolutions. Resolutions take work. I just want the benefits. No, actually, I want to focus on supporting my daughter to develop her cricket skills in 2024 and her love of cricket. She's doing amazingly well, and so I want to keep supporting that. And I also want to try and assist my wife to find more space and time to work on her own creative projects rather than my podcast.
Happy wife, happy life, as they say.
Indeed. Do we need a podcast resolution? Get better at podcasting.
That's a weekly resolution.
And by the way, I've just checked, and 2027 will be the year of the goat. 2024 is actually the year of the dragon. So I just made up stuff in the intro.
Yes, I could have told you that. My youngest son is a dragon. And for this entire millennium, if you're good at your 12 times table, it's really easy to know when it's the year of the dragon because it's just multiples of 12. So 12, 24, 36, 48, etc.
So you've got a Swiss passport, we learnt recently, Italian heritage, and now you're claiming some kind of Chinese heritage as well?
Only by marriage, Dixon. Only by marriage. And Natalie only claims it genetically because she's as Aussie as they come. Doesn't speak a word of Chinese, doesn't read it, doesn't even like rice. She actively dislikes rice. But don't forget, in addition to the 12 Chinese zodiac, there are 5 elements as well.
Oh, okay.
Wood, fire, earth, metal, and water. Each 2 years has the same element. So it goes wood, rabbit, wood, horse, and then earth, duck, earth, snake, etc. Right? So it goes around every 60 years.
Okay.
So this year is wooden dragon, and in 2025 it's wooden snake. And then it changes so that in 2026, it's fire horse. And that means that 2027 is fire goat.
Fire goat. I like that. There's a good merchandise idea, Gaylard.
Oh, yes.
Fire goat cap.
Definitely. That would be good.
Anyway, I did say New Year spatial resolution deliberately in the intro. And that's because today we're going to listen to a CT technology discussion recorded at Radiopedia 2023 back in July, hosted by Andrew Murphy and featuring radiologist Ben Hudson and imaging physicist Professor Tim Szczykutowicz. They'll chat about things like dual energy CT, photon counting CT, and how not to get sucked into spending millions of dollars by vendors.
Oh, that's going to be interesting. I was reading an article or something recently about how marketing changes during the life cycle of a specific technology and how initially it's all about the features. So if you think of phones, you should buy the new iPhone because it has better battery life or screen size or better colors or memory or weight or camera specs. But then when everyone reaches the level where improving those things doesn't really help, which I think you can argue we're kind of there, it pivots to marketing on the basis of how it makes you feel and the kind of social signals that you're giving out. So you get endorsements by celebrities, you get different colors, you might get different materials. And I wonder if we're going to get that with CT and MR, that all the marketing will focus on what color your CT scanner is. And this one is the Bono U2 limited edition Siemens scanner.
Like wearing a fancy watch, that kind of thing.
Yeah.
I won't hear a word against LED strips. So I reckon every scanner should come with a purple Radiopedia glow that it casts in the room.
Oh, I've got purple LEDs under my bed at home.
Of course you have. Goes with your purple Radiopedia jammies.
Yeah, that's right.
Now, just quickly before we get into the main segment today, I want to mention that registrations are now officially open for Radiopedia 2024. That's our 5-day virtual conference taking place from July 22 to 26. The full lecture lineup has been announced, workshops, etc. So please do go and check that out, get registered. It's going to be amazing.
Don't forget also the art poster abstract submissions are open as well. So it's your chance to use a bunch of cases from the website and create an educational poster, get it published at the conference. You get a certificate, a DOI, a digital object identifier, if you care about these things, and everything. It looks fantastic on a CV.
You get everything indeed, including a fire goat cap, maybe, to the author
fire
of the best
goat
poster.
PJs, purple PJs with fire goats.
All right, well, let's get into the main segment now. So, a CT technology update with Andrew Murphy, Ben Hudson, and Tim Szczykutowicz. We'll listen in, and then Frank and I resolve to be back for another chat in the outro. See what I did there? Resolve.
Very clever. Very clever.
Hi, and welcome to our extended CT panel where we're going to talk everything CT. My name's Andrew Murphy. I'm a radiographer in Brisbane, Australia. And here with us today, we have Dr. Ben Hudson, who is a consultant radiologist at the Royal United Hospitals in Bath in the United Kingdom. And we also have Associate Professor Tim Szczykutowicz, medical physicist at the University of Wisconsin. Ben and I, Tim, have been doing our homework and we've been perusing your textbook to prepare for this today. And Ben, I've been reading a lot about cardiac imaging to make sure that I don't make a fool of myself in front of a consultant radiologist who reads cardiac scans all day. The main thing that a lot of people are interested in with CT at the moment is dual energy scanning. Every vendor is offering some shape or form of dual energy CT, and they're really sprucing the clinical applications and how it's going to change clinical practice, and it has been around for quite a while now. Ben, I'll start with you. Are you using it locally at your practice?
Yeah, so we've been using it for a few years. Some sort of limited applications, so we do dual energy for pulmonary angiography for certain patients, but not all patients. And we do some bone marrow edema imaging for trauma patients, some gout imaging. So some applications, but we don't use it across the board. It's quite a select thing that we do, and with different types of scanners and do them in different ways. But yeah, not sort of across the board. Maybe slightly ahead of the curve locally, but maybe quite different to some bigger centers or those with a lot more experience.
Yeah, that's interesting because at one of the centers I work at in Brisbane, dual energy seems to really dominate the scanning protocols. With anything, there's an element of it's driven by there's the potential for research in the future, and then there's the element of it could have a clinical value. We definitely use it a lot for our CTPAs, and it tends to be the favourable scan with the iodine maps and things like that. Do you find the bone marrow maps in trauma useful at all, Tim? Do you have much experience in the bone marrow stuff?
I know some of our radiation oncology folks have looked at that for looking at radiation damage or where to avoid and try to save in the bone, but we don't use that in diagnostic radiology currently for the bone marrow. Most of our uses are simply for better conspicuity for small enhancing lesions, say. So we're mostly utilizing lower KEV images or iodine maps. And then that's in the body. And in the head, we have one protocol that's pretty popular for the patients post neurosurgery for stent removal to look at blood staining in the head. That's our main application there. We've tried for pulmonary embolism for PE, but I think we like the speed that you can get with single energy better. Usually with most any dual energy mode by most any vendor's technology, you have to go a little bit slower. So we like the single energy for its speed there.
We definitely see the use of those virtual non-contrast heads post endovascular clot retrieval for contrast staining. That tends to be our mainstay dual energy application that is asked for if it doesn't automate once it's sent, and it tends to be the thing that's clinically utilized. Tim, could you briefly explain to us the difference between, say, I had a dual source scanner or I have a spectral scanner where dual energy is always on? Because that tends to be a point of confusion a lot when people are kind of shopping for CT scanners.
Yeah. So I don't go in much for the vendor trademark names and things. I think at the end of the day, so we don't get confused as people actually using this technology, whether we're physicists or radiologists or radiographers, there's nothing magic to one solution or the other. In the dual energy space, so if we're not talking about photon counting, every vendor that's implementing dual energy, and some of them may call it spectral imaging, they're really just acquiring two different effective energy data sets of the same part of our patient. So whether they're doing that with a dual source where they've got one tube acquiring one energy and another tube acquiring another energy, whether they're doing that by quickly switching between low and high energy beams, or whether they're doing that with a detector which has two different layers, one sensitive to one energy and one sensitive to the other, or there's another solution that one vendor has where they have one beam, one tube, but they have a bow tie filter that has different filtration on either side, and that changes the effective energy. And then I hope I'm not leaving anybody out. I think the last solution that's been used is just to simply have a rotate solution where you do a scan at one energy and then you do a scan at another energy. So every single one of those approaches I just mentioned in my mind is a spectral solution or is a dual energy solution. I wouldn't get lost in a vendor somehow saying they're spectral and that's better or different. They're all acquiring two different effective energy data sets. People using this technology on real patients, important questions to ask the vendor are: how fast can you scan? How long of a scan range at a high dose can you scan? Those are two important questions because these various technologies, some of them are pretty slow scanning. Some of them require very high tube currents, which could mean you can't do a 3-phase abdomen, for example, or you may not be able to do a dual energy delayed phase on the third phase of a torso exam, etc.
That's certainly something we find. We use dual source CT for our dual energy, and one of the disadvantages there is the field of view. So if you're doing a CTPA dual energy in a large patient, you might not even actually be able to see all of the pulmonary arteries or the periphery of the lungs. So like Tim says, there's a payoff for all the different types of setups for dual energy.
We always talk about what's the killer app for some new enabling, technology? What does it enable? Maybe, I think it's undoubtedly so that dual energy has enabled better gout, or kidney stone, quantification. And that's actually pretty good because most any dual energy or spectral technique, you don't need super high speed for those types of quantification tasks. So if you really thought it was worth spending the extra million or however much, dollars, whatever your currency is, on that technology to have the one or two killer apps that dual energy can enable, then I guess speed isn't as much of a important factor for those.
Yeah, I was just a general point really about what Tim was saying about vendors selling their hardware, which is their job, but you do get a bit caught in the headlights sometimes when you get shown these scanners, all these great specifications, and look what it can do, but it's that real life clinical application that's the reality, isn't it? You got to get away from the table with all the merchandise and the really nice reference site visits and really have a look at how it works in real life and with real life patients, and we're seeing a increased number of patients with higher BMIs and stuff like that, difficult, challenging scenarios and with which to scan, and not just the picture that's up on the lecture screen and it's just, it all looks magical, it's great. We find that the reality is quite different. I guess that's life, isn't it? But
yeah, if it were me or a loved one and I wanted to go to the hospital, I think I would my lead CT tech I work with every day and maybe my favorite radiologist on an old, 10-year, 15-year-old state-of-the-art CT scanner that everyone knew had a really good workflow for. Maybe outside of a cardiac application where I probably would want one of those expensive new premium scanners from today. So I guess, Ben, you're a cardiac radiologist, so you can still have an argument for the fancy toys, but for most of the what I'd call bread and butter routine imaging, I mean, the spatial resolution and temporal resolution and scan speeds that we've been enjoying for almost, 2 full decades, like they would be adequate in my opinion for most of those bread and butter applications.
For me, there's a massive fear of missing out whenever you're looking at a new CT scanner, and the number of CT scanners is a little bit like the number of bikes you need, or like cans of beer you need, if that's your thing. Like it's n+1, where n is the number of CT scanners you currently have. In the UK, we really do thrash our machines, and we need the option to be able to flip between lots of different indications, lots of different types of scan, acute patients, elective patients. So that's the way I try and justify a lot of this stuff, is if you need that flexibility, try and get the best scanner that you can for what you're going to use it for. And dual energy is just, for us, is just on the sort of, it's like always just on the horizon. It's an extra step, which it definitely has its applications, but getting the opportunity to use it with like validated evidence. So we talked about CTPA. The European guidance for dual energy CT for CT pulmonary angiography it basically says, well, think about it, but the evidence isn't there to validate its use constantly. And so VQ is actually used in the guidance for that kind of stuff. But it's certainly an area where it gives you that sort of one-stop shop availability of doing the pulmonary angiography and looking at the perfusion maps at the same time. But with all the caveats that you guys have mentioned already around speed of the scan, these patients are intrinsically probably a little bit breathless, and maybe larger patients, depending on what the reason they're having the scan.
I was going to say, one thing we haven't talked about with dual energy is kind of, if you go to outside of academic radiology, right, go to the real world and you talk to a radiologist, what I always hear is, they're like, this is like MR now, right? Because you've got all these extra image series. So I think, one way I kind of look at is the real value from dual energy. Sites that can really realize the value are a lot of times academic radiology centers where they've got a huge team of people that can invest a ton of time tweaking the protocols, figuring out exactly what image types they want on a vendor model specific type basis sometimes for each indication, of course, and then build those protocols and run that workflow, train their radiographers or, their technologists on how to scan it. And that's not reality for, a lot of folks. So I think people trying to get into the dual energy game now that don't think they need like all of those resources and effort, I think they're not going to see value. They might actually see negative value because they're actually complicating a lot of people's workflows in life if those people aren't given the right resources. So I'm sounding a little pessimistic maybe today about dual energy. I think there is gains in the right hands, but it's not a perfect fit for every imaging practice culture.
It's worth noting that a lot of the research on this, it's retrospective studies that are published in high-tier journals, and it gets people very excited. But we could talk about this for another half an hour if we wanted to. But we'll move on to CT protocols and cardiac imaging, because that tends to be quite a challenging aspect of any CT department. You get new radiographers or experienced radiographers. They all can kind of do things like your chest, abdomen, pelvises, your oncology patients, and even most trauma scans aren't really technically difficult until you start looking for very specific, aortic pathology plus minus a pulmonary embolism or something like that. Cardiac imaging tends to be the sticking point. So whenever you go to like a new workplace and there's a cardiac imaging portion of your CT training, even if you've done it before, you are really just starting again, because every CT scanner, every radiologist has a different preference. Now, Tim, you've made a lot of CT protocols and shipped them out to thousands of centers around the world. Do you find that you have to make specific changes to your CT protocols based on radiologist preferences, or are you finding there's starting to be a trend more to retrospective scanning rather than this prospective scannings?
From our experience at our institution, we do have a lot of gated protocols with very specific targets for different cardiac phases, and then some multi-phase protocols to look at different anomalies, and sometimes, different contrast injection schemes. and sometimes in some non-gated, phases through the heart and through some of the rest of the descending aorta. So at our center, yes, I find that's the practice. And I think from my experience at other sites outside of our institution, I think that is common. If you're getting indications for device planning, then you probably know what you're doing and you probably have really tailored protocols. I don't see, at least in the US, in the sites I have experience with, someone out in the rural place with like 1 or 2 scanners doing some sort of, elephant gun type protocol where they're collecting like whole beat, multi-contrast phase cardiac protocols. That's just not common because of the nature of cardiac interventions. You're going to have to go to the mothership type health center in your region, and they're going to have usually then tailored protocols for cardiac.
How about you, Ben?
We supervise all our scans, actually. So we've got a radiologist there the whole time that the cardiac CTs are happening. So we work with our radiographers. And my practice is quite sort of bespoke. I'm looking at the patient, looking at the ECG, and looking at the question. For me, cardiac CT's a little bit like an annoying relative. Like, I've got unconditional love for cardiac CT, but I am often disappointed. So it's about using the protocols on a bespoke level to try and get the best out of the situation. And obviously you don't know what you're faced with until you're there. You were mentioning sort of retrospective stuff, Murph. Almost never use retrospective studies unless there's a contraindication to cardiac MR. You want to get some volume analysis or something like that, and you need the whole cardiac cycle. So prospective for nearly everything. Try and get the heart rate down as best we can. Diastolic imaging if it's really low. We've got dual source CT, so we try and use that ultra high pitch mode if possible. And then we use a lot of systolic imaging, actually, so irregular rates or high heart rates over 65. We do a bit of stuff around aortic valve intervention. Tim mentioned that kind of stuff. There are lots of options, and I think a lot of that is about your sort of apps team and what your tertiary center is actually looking for, what they're willing to accept as well.
Yeah.
So we do something fairly basic from that point of view, prospective imaging of the root and stuff, and then we do an ultra high pitch of the rest of the body. So I think a lot of it's tailoring the stuff to your practice, to your patient and stuff, and trying to work around the pitfalls of cardiac imaging in general.
I'm just curious, Ben, what your thoughts are. I think one issue that we've dealt with and are always probably will deal with is communication. As a physician, I'm sure you know what's the best phase for a given indication, right? And that may change depending on like that how that patient presents day of with their heart rate or their variability. And I think this is one place where we're constantly making sure we have memos going out and we have documentation in our protocols for on this specific CT scanner for this indication. If the heart rate's in this bounds or has this variability, you need to use this bell and whistle option on that piece of equipment. And then even if this happens during the scan, you might need to do this, play around with the cardiac trigger, the windows to get the radiologist what they want. I would say it's probably the most complicated workflow for having a mapping between one clinical indication and what the radiographer or the technologist is actually going to do at scan time. And I guess if anyone is listening to us talk today, that would be my biggest recommendation is if you naively believe that you have one state-of-the-art CT scanner, it's not like some magic thing that's just going to automatically always adjust perfectly to every indication and patient presentation. You really need to understand the technology with the apps people and then talk radiographer, maybe your physicist or technical person, usually probably a vendor apps, and then obviously the physician or the diagnostic cardiologist to understand how to get the most out of that piece of equipment.
Absolutely right, Tim. And you've got those sort of 4 variables, haven't you? You've got the patient, the heart rate, how they're made, how much calcification they've got, that kind of stuff. You've got the machine, which you can't really change once you're there, but having that sort of intimate knowledge of what your machine is capable of that takes time, that takes experience with the team working with that machine, and that goes back to what we said about, you know, how the machine's sold as this bells and whistles thing. That's not the reality, so you've got to get used to what the parameters are. And then you've got the radiographer, massively important. They know how the protocols work, how the machine performs, and following those protocols. And then you've got the most complicated bit, which is the radiologist, who's never happy and may or may not be present. We're always present in the next room, but in terms of communication, Tim, what they do in our hospital is they either shout around the corner and say, "Come and look at this. Are you happy with the heart rate? There's loads of calcium. This isn't right." Or they bang on the wall, and it's like it's a Pavlovian conditioning. You hear this knock, and then you go running around, and that all comes
the
back
old bang
to
on the wall trick.
It's fine in Bath. We're well trained, but it goes back to that cardiac imaging being one of those types of exam where you can't just be removed from the process, or you will be disappointed. And are you willing to let the patient go from the scanner with a non-diagnostic study? Or are there things that you can do to optimize before you scan? Or do you need to change tack? Or you look at the scan and you go, well, actually, we need to do something in a different way. From that side, it's really one of the most, for me anyway, and I'm clearly biased, the most interactive types of scans that you can acquire with CT, and it depends on the whole team, all those variables, the radiographer, radiologist, physicist as well, obviously, in setting a lot of this stuff up, and then the machine and the patient as well. And it's like you've got to just get all these things, all the stars aligned, and it's amazing how often that does happen, but similarly, sometimes it doesn't work so well. So you're just working your way around those things.
I think what makes a huge difference with cardiac scans, which are arguably one of the harder scans that you can do on a CT scanner, and a lot of CT scans, is that if you have a team of radiologists who buy into the radiographer's professional development and actually explain to the radiographers why they want to see something and why it matters to the patient and why it matters to the diagnosis, it goes like a really long way. Because instead of having a radiographer who just remembers that you go into systole when the heart rate gets higher, if you explain to them why you're doing that, the ECG gating, and how when you go into a higher heart rate, the diastole starts to shrink, if you can explain all that to a radiographer and show them that you trust them to understand what you're saying, it tends to make a better team where you have buy-in and everyone's kind of on the same level. So I've worked in a lot of departments in Australia, in Canada, in both pediatrics and adults, and the biggest difference I saw in departments where they were like, just press the button, get it done, we'll figure it out later, and the departments where the radiographers knew exactly what they were doing and why, it was huge. Like, you get really high quality scans and really passionate radiographers who aren't just saying, hey, can you look at this scan? They're saying the RCA looks kind of blurry on this scan, and I think we need to repeat it, but I thought I'd give you a call. That helps a lot with this stuff, because I think the radiologist just assumes that we just know how to use the scanner, and we do. That's what we're trained to do, but there is that extra level of like, hey, why don't you come to our teaching at lunchtime and we'll do a session every month where we just go through these type of scans and we'll explain to you why we want to see it this way. Like, it helps a lot to do that.
That professional development's massively important, and getting familiar with the scanner that you have, with cardiac imaging in general for radiographers or techs is huge. And it's certainly, it'll be different in different parts of the world, I'm sure, but in the UK, trying to get as many patients through the scanner as possible, getting through backlogs, and forgetting that quality is really important, quantity is important, but getting the right scan, not having to do another test down the line because you didn't take the time with the radiographer to train them properly, for them to go to different hospital sites, to go to the vendors, to go to cardiac imaging conferences and understand what they're doing, rather than, as you said, Murph, just hitting the button and hoping everything's going to be okay. That's a massive, massive part of this puzzle.
Yeah, I will say that, well, first, Murph, when you said that the radiologists assume that the radiographers know how the scanner works, I had to chuckle a little bit inside because honestly, with modern scanners, I think they're getting so smart, and they're actually, I think in some ways I've seen them make the workflow better because they can do a lot more adaptation to patients' heart rate and heart rate variability. However, with that comes a level of complication and or complexity rather, where we've three major OEMs, of course I won't mention by name, where I've asked questions about different parts of that type of a workflow for smart kind of cardiac, and you get multiple responses at different levels of apps and engineering support where they're not exactly sure how it's going to work. So I think in my experience, we've gone a long way from the technologists having pre-built protocols for various heart rate bands, right, or various different types of variability that are kind of pre-built to help the technologists, or we've come a long way from having the techs make those adjustments on the fly to places where some of the scanners in my fleet, a really wide range of heart rates and variabilities, the scanner will automatically adapt to, and the radiographer doesn't have to make any of those decisions. So that's really cool to see. I think there's still some kinks from any vendor I've seen's product, but it's better than where we were a while ago. But they're still, pretty complicated. That's all. I don't know if you guys have experience with any of those systems.
It's the AI thing, isn't it? It's like the automation is pretty good, but you still need to know how it got to that result so you can correct if it's getting to the wrong results, right? It tends to be how I've found, even with the better scanners, a perfusion map on a stroke patient works 99% of the time, but when it doesn't work, you need to figure out exactly why it's not working and how to go into the back end and change, reference vessels or from max slope to some other type of calculation. So yeah, I guess it's the choice you have to make as a radiographer and as a site as to how much you educate your staff. And I've had the similar issues where I've contacted certain vendors to ask them about very simple things like, what do the colors mean on these maps? And they will actually say, commercial confidence, can't tell you, sorry. It's just one of those things, which is, it is what it is. But it tends to be the environment that we're in where we're trying to get information and they say, yeah, we'll give you a white paper for it. And you go, great. And then the white paper you get doesn't make any sense, and it's all proprietary technology that they can't discuss. And you feel like you're slowly getting stupider. So I think there is no better place to end this discussion than on photon counting, because it would be amiss of us not to talk about the thing that every CT vendor is talking about at the moment. Tim, I know you have a few opinions on this, so we'll start with you. What's your take on this new CT technology that seems to be coming out quite quickly?
Undoubtedly, there's definitely gains in the high contrast spatial resolution. So things like MSK imaging, temporal bone imaging, probably any kind of bone imaging, probably some lung imaging for Ben, in the heart, probably getting less blooming from calcium, and maybe that'll translate into more accurate FFR things for you, Ben. I don't know, but those types of applications, I think, just due to the nature of the smaller detector pixels, I think we're going to see I know we're going to see better spatial resolution. It remains to see how that will actually impact patient care. If we can see things we couldn't see before, if we can see things at earlier stages, or just characterize things that we see today, but they have to be 3 times bigger, and now we can see them when they're smaller earlier in the disease progression or so forth. So that's probably the most exciting thing. Actually, anyone that's listening, so they understand why the gain happened. Well, because in photon counting, you're literally counting each photon. So you have to count on the level of each few nanoseconds you're counting a photon. Whereas in energy integrating, you're counting over a millisecond. So it's a huge difference in time. So because it's a really hard job to count that much, what the vendors did was they realized if they made their detectors smaller and smaller, they would see fewer photons, so they'd have an easier job counting them. So that's honestly, in a nutshell, why we have smaller detector pixels today, is because of these issues with it was really hard to count a lot of photons. So anyway, but back to the other half of kind of photon counting is the spectral nature. And this is where, don't let any vendor fool you. Photon counting, when it comes to this spectral imaging, so we're talking about iodine maps, monochromatic energy, etc. That is just giving us the same types of image presentation that we had with dual energy. And the verdict is still out, and it's being actively researched if it's providing that information better. In fact, some evidence now, in talking with researchers working on current, FDA-cleared products, says it's got actually worse energy performance than some state-of-the-art dual energy scanners. In my mind, I categorize that, and I'll stop here. High contrast space resolution, for sure, there's a measurable big increase, and we need to figure out clinically the impact. And then the second one is, yes, it's giving us what dual energy gave us today, your iodine maps, monochromatic, effective atomic number, etc. That may be just as good as today's dual energy information or slightly worse, but that's kind of still being researched.
How big are the file sizes compared to a conventional CT? From what I've read is that you get the spectral scanner, but then you also need to update your PACS infrastructure because you're going to have a massive data sets.
I don't think we talked too much about, or maybe I mentioned it a little bit, that radiologists might complain CT's becoming like MR. And I think, like, if we're going to go forward and effectively, like, unless you're planning to do research and you have a few more $1 million laying around and you want to play with a new toy, then maybe you want to send around those big data files you're referring to PACS. But if photon counting and really dual energy is going to break out and just be standard clinical routine, I think as a community we should figure out what types of images, say, Ben needs for the heart, and what types of images a neuroradiologist needs for a not regular non-con brain, etc. Personally, I'm not a radiologist, so I can't speak for them, but like, it doesn't make sense to me that we really need on-the-fly information available for them to create any type of spectral, image under the sun on PACS. So if you wanted to do that, yeah, then of course you need to send this bigger, fatter file set up to your PACS.
Well, lucky we have a radiologist here. What's your take on this, Ben?
Yeah, radiologists always want more, don't they? And they're always disappointed at the same time. So I think that is probably a problem that you might have to face. The costs are pretty prohibitive for most hospitals, I guess, with considering photon counting detector CTs. It's probably the last couple of years where I've gone to these cardiac conferences and they're starting to push them now. I'm only aware of, I think, one in the UK at the moment, and it's still being used sort of research and maybe very early clinical, and that may be vendor specific. I'm not sure how the other ones are going. There's a perceived definite benefit with cardiac imaging, because you remember we're imaging things, coronary arteries that are maybe 4 or 5 millimeters at their largest, most people are maybe down to 1 millimeter. We know the benefits of cardiac CT. It's moved beyond stenosis by some margin, and we're about plaque quantification in terms of volume, non-calcified versus calcified, and then these high-risk plaque features, because we know that these are the things that actually affect patient outcome. And some of those things are beyond the resolution of standard, conventional energy integrated detectors. So that notion is correct, that maybe you do need to get that extra information if you're going to affect patient outcomes down the line. And again, you get dazzled by these amazing pictures that you see in conferences, and particularly around calcific plaque, where you're going to get partial volume averaging. Stent imaging is a big thing that might come in the future. More intervention.
They love showing the stent imaging.
That nice clean stent, and you have these moments where you're like, well, that's not what my scanner looks like, and you got this massive envy about it. And it's like any sort of teaching or lecture you give, you show your best pictures, don't you? This is what my scans always look like. But you talk to the people doing this, and it's not necessarily the reality of every scan that they do, and they do run into problems patient specific. So I think it's a great area to be advancing in cardiac. I don't know about the other sort of applications as such. I don't know what you think, Tim. Is it 5 years, 10 years where it's going to be routine clinical application? Are the costs for solid state detectors going to come down to make it available? Are they going to just try and make us all buy one when it's really expensive and then wait another 20 years or something?
We can't tell the future, but I think it's a very fair assumption that the costs would come down. I'm not sure I've seen enough evidence for routine bread and butter imaging why I could ever advise a site that they needed photon counting today yet. For cardiac, I could easily see photon counting, making a big impact. But I'd really like to see, like a New England level type study journal type study where it's like, oh, because we had, photon counting, like we could implement this better metric and make an actual impact in patient outcome. I think that's what I'd like to see before I could ever tell a site, yeah, you need to spend like $2 million more or whatever it is going to be, US dollar on a photon counting scanner. But yeah, bread and butter, I don't see a path today. I think some niche neuro applications, temporal bone, like coronary, then I could easily see, within 5 years, the evidence being out there. I mean, I'm sure the vendors think the evidence is there today to support purchasing one of their premium scanners. But still, I could never recommend that for bread and butter. So I think in countries like in the UK and others where they have it's, in the US, we can basically just kind of figure out, like in my hospital, like what we want to buy and go buy it. We don't have such a bidding tender process like in some parts of the world. So I don't know what extra kind of games have to be played to justify, spending so much more money on a scanner.
That's about all we have time for today. So Ben, Tim, thanks for joining us, and we'll see you all next time.
Yeah, so did you get your wish there, Gaylord? Did they bag out vendors enough for you?
Look, I'm not some sort of aluminium hat-wearing anti-big pharma Comtrail conspiracy theorist, all right?
Not anymore.
I think the vendors are great, and they're at the very heart of why radiology has gone from just taking occasional x-rays to everything that we're doing now. But
the vendors are going to clip out that last little bit. Just that I think vendors are great, and then that's it. That's all they'll use.
That's on the poster. 5 stars. But I think it is really important to tease out genuine innovation from...
Genuine? What did you say? Genuine.
Genuine? Okay.
Yep, that sounds better.
Genuine? You want to go with that?
I think so. I mean, words are important.
You don't want it genuine on the poster?
Yeah. So I think it's really important to tease out genital technological innovation.
All right. Genuine tech innovation, which I think photon counting is likely to be an example of that, from marketing hype. And the importance, I think, of doing that is not just so that you get suckered into buying an expensive new toy that doesn't actually do anything different, but because if you do get suckered in and you don't dismiss trivial differences, then what you're creating is an incentive for vendors to focus on trivial differences rather than focusing on the really important changes. Yeah. And that means being aware of the terminology and the technology that underlies it to know when you're talking about something genuine or different or if it's hype. And I think that talk was really good at describing how some of these things are actually all the same and they're just using marketing glitz.
Yeah, when you get an expert like Tim who doesn't have that loyalty to a particular brand and can cut through it all and just understands the physics and what's behind it all, it's good. Yeah, dual energy is a good example of what you're talking about there, because at my hospital, it really hasn't progressed beyond the niche areas that those guys talked about, and it doesn't really justify getting a new scanner and the cost. Yeah. Has that been your experience as well?
I mean, I think so. I don't do much CT anymore, so to be honest, I don't know. I know we use it for vertebral body fractures to see whether there's an acute or chronic. I know we do it I think we do it for gout, and we definitely do it for contrast staining versus hemorrhage following cerebral angiography, which is really useful. And then the bit of virtual non-contrast imaging too, I think.
Well, you can't go wrong with virtual, mate, especially virtual conferences. We do the same. And we don't do the vertebral body fracture one, though. I always wonder how useful that is, because often you'll have a fracture and then you'll do an MRI, on the same day or the second day. You can see the fracture on CT, you do the MRI, and the marrow edema is actually really, really minimal. It's actually sometimes hard to spot acute fractures.
Yeah, I haven't had that many cases where I've thought, oh, this has really helped me.
Yeah. It seems again like a solution looking for a problem, doesn't it? Rather than, we're really struggling to spot fractures on CT. We really need dual energy to help us.
Well, I think that's the thing with a lot of these new tools, and AI falls into this as well, where the thing that they claim to do might work really well if you consider that question generally. But in the subset where it's hard with existing tools, it also struggles.
Yeah.
When it's obvious, then I don't care if AI can also spot the fracture because I don't need it. And when it's hard, that's when I want it. But that's not what the papers show you, and certainly not what the companies tell you. They always give you the overall performance. And I suspect that a lot of this dual energy is similar, where it's particularly good at showing you things that you already know. We're going to get hate mail from all the dual energy supporters now.
Anything else to chat about from this one?
Well, I also found the conversation about interaction between radiologists and radiographers really interesting. And we've spoken about this before, I think, but the idea of hoarding knowledge is just rubbish. That idea of this is radiologist knowledge and you are a radiographer, therefore you should just do as I tell you without understanding why, is short-sighted and protectionist for no good reason. Whereas I think if you take the time to teach and explain, or even just like we spoke about, I think a couple of weeks ago, just give a reason why you're doing it, even if it's not a great reason, it really helps you engage people in your workplace. And everything is better in the future. And the amount of time that it takes you to explain is easily won back in future efficiencies.
Absolutely.
As an aside, I run into this problem. It's not a problem. I'm the problem in this case when we do feature development at
That's
Radiopedia.
The first step is admitting that you're the problem, Frank. Congratulations.
Baby steps, one step at a time.
2024 is going to be a big year for you.
It's big year. But so we'll come up with a feature that I want Radiopedia to have, and I'll create designs and mock-ups and explain how it will work and how it should look. And then I give it to the developers to sort of put it in place. But if I don't also explain why we need this feature, what problems is this feature going to solve, how is it going to be used, then often they will do as I told them, but it's rubbish because the way I've told them ignores all sorts of really important edge cases or aspects of how the usability will be affected that I haven't considered. Whereas if I take the time to explain the context, often I get pushback and the end result is much better. And I think the same is true when it comes to protocoling or scanning.
And as you said, it only often takes a couple of seconds to give that kind of context rather than saying to the radiographer, no, stop the scan there, we're done, we don't need to give contrast. Like explaining to them what your reasoning is behind that decision means that they'll be better able to predict what you're going to do in the future and know when to call you up and what questions to ask. Now, what did you think about the comment about standardizing protocols? I'm probably a little too relaxed myself, and I'm pretty happy to report whatever sequences or phases come my way, but you're a bit more pedantic, I imagine, and have very specific sequences you like included.
Funnily enough, no. In fact, this is possibly one of the sources of not really conflict, but minor conflict that I have at work, because I don't really fall into this idea that there is one true platonic protocol that we need to kind of strive to achieve that's perfect. I think in retrospect, after you see the scan, you can imagine which sequences would have been really helpful. But predicting ahead of time is pretty hard, and there's lots of different opinions. And I'm much more of the throw some sequences at it, and as long as they're not really dumb, then it'll be fine. I mean, if you're looking for, something to do with vessels, you probably need MRA in there. But exactly what kind of sequence and what slice thickness and I don't know. I don't care. And I think the advantage of being a bit more flexible is also you get less reliant on having to have exactly what you're used to. And you notice sometimes when a particular sequence is really helpful, and maybe then it becomes more of a habit to include that one.
I think it also helps avoid the inevitable bloat in the number of sequences you're performing, right? Because if this person finds this sequence useful and this person finds this one, ultimately what you end up with is every sequence being performed every time. Whereas I much prefer the approach where you do your routine MRI brain with just your standard sequences, and then you spot something, and then you go, okay, now it would be appropriate to go on and do this other sequence, rather than performing that every time.
Yeah, that's interesting, because I think there's two aspects to that you're trying to balance. One is, how much supervision does the scan need? And you could just sit in front of the scanner with the radiographers and look at each one and craft a bespoke protocol for each patient. And you see that in cardiac, particularly, in some other complicated areas where you really struggle to have a generic protocol. But then you're only doing a dozen scans a day. And on the flip side is, if you don't do enough sequences, then your recall rate will be too high. And so you need to balance those two out. But what I see a lot around town, and when people talk about recall rates, they talk about it as if you would want your recall rate to be zero. And I think if you find a department that has a zero recall rate, either they're not calling people back that they should, or they're scanning way too much.
Yeah.
There is some number of recall that's efficient, and that will depend on where patients live and how easy it is for them to get into your hospital. But you should be optimizing for the efficiency with which you can get people back for those additional sequences, and have a number that you're aiming for, just like inflation. You aim for 2% inflation or whatever it is. Well, you should aim for some percentage of recall. And if you're too low, then you should cut more sequences out until your recall rate goes up, until you reach that optimum level.
I think there's also an argument sometimes that you need to be performing enough of a certain sequence in order to get your eye in for it. So if you're only performing CSF flow studies in very, very tight number of circumstances, you might not have the overall experience in order to be able to interpret those ones when they come through. So if you're a bit more lenient in when you perform it, heard those arguments kind of given as well. So there's obviously a balance.
Yeah, and I think there is weight to that, particularly when it's a new sequence and you're not used to it. And I think CSF flow is probably a good one, because if you're not performing it on pretty much normal people, then you won't know what your normal values are going to be. And that's, I think that's actually a very good example, because the values that are published in the literature and that people talk about, we did a set of control studies in just random normal young patients and elderly patients with no history of normal pressure hydrocephalus or anything. And the values were often higher than what the literature would talk about. And that was really helpful, because then internally we knew that before we could say that this was hyperdynamic, we would be using values of like 150 rather than 80 or 100 that most people would talk about, let alone 42 from that paper from 1902.
Well, we better wrap this discussion up. I just wanted to thank Andrew Murphy in particular for organising that panel discussion at Radiopedia 2023, and he's back as one of the co-conveners for Radiopedia 2024, and it's great having that radiographer perspective at our meeting.
Absolutely.
Frank, how can people get in contact with us?
Well, we're at Radiopedia on Twitter and Instagram, as well as at Frank Gaillard and at Dr. Andrew Dixon. And you can, of course, email us at podcast@radiopedia.org with any ideas and feedback.
Mm-hmm. Do you want goat-related merchandise? Let us know.
Fire goat.
Everyone wants it, I'm sure.
We might be able to organise that by 2027.
I think, look, if we just order an initial print run of, 10,000, we should be fine. We'll be able to get rid of that.
Purple goat pajamas.
Yeah. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our entire online course collection and our annual virtual conference. In doing so, you'll be helping us to give free conference access to people in 125 low and middle income countries. And what else can people do to help us out, Frank?
And you can also help out by leaving us a 5-star review.
2024 has already beaten you down.
If you're choosing.
That was terrible.
We should ask for some 1-star reviews.
No, don't. You can't do that.
They're not funny. They keep talking about radiology.
Or not talking about radiology. All right. And we'll catch you all again sometime soon in the reading room.
Stay right, everyone. Stay right.
New Year's resolution complete. Get better at podcasting. Tick, Gaylor.